Hi, this is Pete Fernbaugh. Welcome to Trinity Talk. My guest today is Dr. Rami Abraham. He's a brand new specialist with us in robotic general surgery here at Trinity Health System. And we're so glad to have you here, Dr. Abraham.
Thank you very much. I appreciate you having me.
We are recording this on your month anniversary. You started here on August 4th.
Yes.
And we're so grateful to have you. A specialist like you make Trinity Health System, make our ministry here so much more. We could go competitive, but we're more about the human kindness aspect, and makes it easier to reach people and to make services that normally were big city services available here.
You have to ship less patients out. When you get the physicians and the staff that are capable of doing some of the more advanced procedures.
And we're going to talk about all of that with robotic surgery. I want to get a little bit on your background so people can get to know you.
Absolutely.
So when we were talking before we started recording, you mentioned that you had moved here from Syria.
That's right, yeah.
When you were 4 years old?
Yeah, 4 years old. To give their kids an opportunity at a better life and a better future, they immigrated from Syria in the Middle East. Close to, what is it going to be, like 35, 36 years now.
I was going to make you do the math.
Yeah, I know. I'm 42. So, so they immigrated here a long time ago to get, for a better future for their kids. Yeah. They left a lot. They left careers. They're both college professors. My dad was a college professor in organic chemistry, my mother in biology. So the sciences were already in the family.
I was going to say, you had no choice. Absolutely. It's in your blood.
Yeah. My sister's an ENT. She's ear, nose, and throat surgeon, yeah.
Those must make for some interesting Thanksgiving conversations.
It does. I don't usually go to anywhere near this place, and she usually doesn't go anywhere near below the neck. So we kind of tackled two ends of the body. But so my parents came here when we were young and settled in Pittsburgh. So I was raised in Pittsburgh, Pennsylvania, and then
great place to be raised.
Yeah, it was nice. We really liked it. I really like Pittsburgh. Winters can be tough, but
getting around Pittsburgh can be tough.
But in the winter with all the hills.
In the winter, all the hills.
Exactly. But then I had a great upbringing in Pittsburgh, and I went to undergraduate study at University of Pittsburgh. I could have done biology like most pre-med students do, but I wanted to be a little different, so I did neuroscience, graduated from there, went to medical school at Temple University in Philadelphia, 4 years, and then did a 1 year internship in the Bronx and at Montefiore Medical Center, and then I finished out my residency at UPMC Mercy.
I think that's one of the coolest things about going into medicine is all the places where you end up training. I think it's interesting because you get a lot of experience in different locations. Pittsburgh is very different from Philadelphia, very different from the Bronx. Yes.
And I saw that clearly when I was there at all those different places. But it makes you a better overall. You deal with different personalities, different people, different cultures, and local cultures. So it makes you a more well-rounded person. So I enjoyed that. Those were all great experiences in my life. Stressful, but that's the field I chose to go into, right?
How many years of schooling was it in all?
So if you're counting undergraduate, it's for college, for medical school, and then depending on what type of specialty that you do, typically it's 5 years. For general surgery, it's 5 years. So do that.
13 years,
14 years. Yeah. Do that. So 13 years. So it's a long time. But in the end, it's totally worth it.
Now, we're roughly the same age. What I'm trying to figure out timeline-wise is when you first went into medical school, was robotic surgery already, was it already not mainstream, but was it being discussed?
No. So robotic, so like the first, specifically, I used called the Da Vinci robot. It's made by a company, Intuitive is the company. They were the first on the scene, and they've
been at it for a while.
They're at it, so there's really other companies are trying to, but I think Intuitive is too far ahead that they're going to have a hard time getting to that level.
They're the first company I heard.
They're the first, and there's others trying to get into it now, but it's very hard for them.
Because I was hearing about them back in the late 2000s.
Yeah. Well, so the first ever surgery that was actually done by the Da Vinci system was actually in Germany.
Okay.
1998.
Okay.
And then in America, and when it kind of got rolled out in America and became kind of an option for a laparoscopic approach was 2000. So it's been around since year 2000. So I wasn't even in medical school yet. So it was there before, but it took some years to get adopted. So I guess question, you know, I was in medical school from 2005 to 2009. And so it was being used, but not very often.
Yeah.
So it did into the mid 2010s.
Yeah.
And beyond is when it really picked up.
Well, that makes sense generationally because early 2000s, you still have a lot of the more old school surgeons still in the scene.
That's exactly right.
Yeah.
You hit it right on the head. Old school surgeons are very hard, especially doing something their whole career a certain way to change at the end.
I mean, 30, 40 years at it.
Exactly.
Use a robot.
Exactly. I mean, and that's I mean, the laparoscopy had been around for a while.
Right.
And so those surgeons, whether it was, if we're just looking, not open surgery, but if we're just trying to look at laparoscopic, compare that, you became very, not even me, when I was in my training, I was in that sweet spot in my residency.
Really? Yeah.
Yeah, it's because I started in 2010, remember? So it was right when the robot was really gaining traction, but still laparoscopy was very heavy because it was the robot was gaining traction, but laparoscopy was still heavy. So I got both.
Yeah, I was going to say that because you came at kind of the right.
I did. Half of my residency was hard laparoscopic. The other half was robotic.
Yeah.
And you had attendings and mentors that did both and didn't like the other, or whatever.
So you had the benefit of seeing the old school way of doing it.
100%. Yeah, and sometimes
absolutely.
There's no now. Patient factors won't allow you to do a laparoscopic surgery, period, a laparoscopic approach. So you have to do an old school approach, which again, I learned that as well. I was heavy on that too in my training. So again, I was telling you earlier before we got on that I really am very happy that I did my training at UPMC Mercy because we had a wide variety of cases, a wide variety of different surgeries and difficulty levels, and then modalities of how to do it, open, laparoscopic, robotic. I got it all during my training there. So kind of luck to be at that moment in time, but also the place, I commend them. They did a great job.
Well, they call us geriatric millennials.
Yes.
That's what they call it.
That's right.
And what I often say is, that the benefit of that is that we have the memory of how things were before things became overly tech-oriented.
So true, true.
Very
true.
I still remember phones with cords.
Well, a lot of my friends and I now, a little off subject, but that they go, nowadays they're like, well, thank God we didn't have cell phones back in the day when we were in high school growing up. So some of those things we don't want captured and be on video for the rest of our lives somewhere. So yeah, we were in that sweet spot where we kind of got to see that transition. Yes.
So give us, those of us who are lay people, give us an overview. When you say we're talking about old school versus robotic, give us an overview of that. So boil it down.
Absolutely, absolutely.
So I'm a bear with small brain. So.
No. I'm a robotic surgeon. Specifically a patient. They're like, well, are you doing the surgery or some computer with a robot doing it? I always tell them, no. The robot is just. You have to think of it as just basically an extension of the surgeon's hand. It's just another tool in the toolbox of the surgeon. Long instruments, that go through ports. It's still laparoscopic surgery. I'm talking traditional laparoscopic. You put the instruments through the ports, and you're at the bedside moving the instruments. Now, those can only move in an XY axis. The tip of the instrument is stiff.
Yeah.
So if you're using a scissors and you're in there, you can only do this. And you can only move around like this. Now the robot, you bring in the robot. It's a machine that has a base and it's on wheels, and then it has a big called boom, and then the boom comes out and it has 4 arms. So once you put the ports into the patient at the bedside, you start at the bedside, you make incisions, you put ports in, and you bring in the robot on the side of the OR bed, and you attach those arms of the robot to those ports, and then on the arms you slide these instruments in.
That's amazing.
And then you move over to a console, and then you sit at a console, and then you put your head into the console, and it's 10 times magnification, three-dimensional view. It's like you're standing in the patient's inside their abdomen and work.
That's incredible. Wow.
10 times magnification. The most important thing for me is that the tips of the robotic instruments are like my hands are in there because they articulate 360 degrees like this. So whatever my wrist can do, with the robot, I can get like my hands inside. Now, if I want to get around this vessel, my instrument can wrap around this now. Instead of like having it stiff, the tip of the instrument articulates so I can get around. The structure is much easier to being able to work right up against something like this, but still be at arm's length and be comfortable.
So and it's important to emphasize, you're still doing the
100%.
surgery.
There's
You've
nothing-
just been given augmentations.
Augmentation. It's like providing a highly advanced exoskeleton to the surgeon to allow him to do things that we have never been able to do surgically.
And does it, and I'm asked this kind of a leading question, but it sounds to me like it lessens the margin of error.
100%. 100%. It lessens the margin of error, and there's many factors to that.
Yeah.
It also allows for the ability to do extremely difficult procedures or cases, very inflamed tissues and things like that, to do it and to be able to do it much safer and take it to completion laparoscopically. There's a lot of times where you start a case laparoscopic and it's just pathology is so bad that it's just not safe, or it's just out of the capabilities of the surgeon to be able to finish that case laparoscopically. So you convert and you have to open the patient up.
Yeah.
You take ports out and you just convert to an open procedure. So the robot, because I've done both worlds, and only I would know because I'm in there doing it. You know, so with my level, there's surgeons, I'm still relatively young. My senior partner here that I joined, Dr. Licata, is a legend around here, him and his dad. And so, of course, skill sets based on experience, they have more. But, it allows you to do, and for me in particular, there was cases where I, was doing them laparoscopically before, early in my career, doing the same level of intense case or difficulty case now with the robot. With laparoscopically, I had to convert. Here, I'm actually doing even more difficult, and I'm not converting. It's because of all those different features that the robot has that allows it to give the surgeon an advantage to be able to do the more difficult procedure and keep it and maintain it laparoscopically. Because once you open, that's a whole different ballgame of complications that can create it. Way more pain.
Hospital stay,
everything.
Yeah.
Bag of morbidities, as they say, like or risk of complication goes way much higher.
That's so fascinating. So I'm also hearing in what you're saying, less invasive.
Yeah,
because there are people who will put these surgeries off because of the whole idea of being cut open.
They're both less invasive than an open procedure for sure.
Yeah.
But then the robot separates itself from laparoscopic surgery in a lot of ways. I mean, we can, there's so much to go over, but first of all, when the torque, so when you're at the bedside and doing traditional laparoscopic, sometimes you really got to wrench that to get to a certain area in the abdomen, and if the patient's very obese and overweight, it's hard to do that because of the body habits.
Sure, yeah.
The robot, the way it's designed, it reduces the torque and traction on the abdominal wall significantly. So that translates into less post-operative pain because it's less trauma pulling on the abdominal wall. So that is an advantage.
Speaking relatively, it's more comfortable for the patient. It's more comfortable
for the patient after the fact.
After the fact,
100%. If you're talking about hernia repairs, this is really where. Well, let's go back a little bit.
Sure.
Very bad gallbladders, very inflamed, very acutely infected gallbladders.
Yeah.
I don't want to jinx myself, but I don't see myself probably ever converting to an open gallbladder anymore since the robot.
Right.
And that's a huge thing. The incision to do an open gallbladder is the most painful incision in surgery.
Oh yeah, when people talk about getting gallbladder surgery,
specifically open.
Yeah.
I'm talking about specifically open.
Yeah.
You got to go through 3 layers of muscle,
Wow.
right? And when, muscle, it's sore if you bump it. I mean, imagine having to cut right through it.
Right.
And things like that. So it saves almost nearly never having to do that again. But again, it separates itself when it's a super inflamed, very, very, very bad gallbladder. And the reason it separates itself is because of multiple things. Number one, we talked about the ability to get around structures and to dissect. There's less, because I'm able to do that internally, there's less trauma whenever you're dissecting and getting around structures. You're applying less trauma, which is less inflammation, which translates to less pain. In addition, there's a thing with the robot, which I haven't mentioned yet. This is super important. It's actually like really life-saving for a lot of so many. There's a fluorescence. It's called indocyanine green.
Okay.
It's a tracer that they inject about a half hour before the patient goes back to the surgery. And then that tracer goes and it gets uptake first by the blood vessels, but then it eventually gets uptaken into the biliary system, into the liver and gallbladder. And then we have a little toggle switch on the robot. Click this, and we click the toggle switch, and the screen that I'm looking at turns into green fluorescence.
Oh, cool.
And it lights up the liver, and it lights up the bile ducts, and it lights up the gallbladder. So this is critical because when you're doing gallbladder surgery, what we call it, we get trained, I mean, it's part of our training, is identifying a view. It's called the critical view of safety, keyword safety.
Right, yes.
That involves making sure you don't see any ducts or vessels that are supplying the liver before you clip and cut the gallbladder duct and artery. Well, you have to obtain that critical view, okay? Using that ICG and lighting up and seeing that common duct and seeing that cystic duct, which is the gallbladder duct, going into that common duct in a environment of just a mess of inflammation and you can't really tell structures, to do a click and be able to see that and safely know, stay away from that area, dissect over here.
Wow.
Imagine the difference. I mean, if we don't have that.
Yeah. It sounds like you're not, I don't mean to,
the safety.
You're not working in the dark as much.
Well, it's completely attainable and you can still do it without having that.
Sure.
But why not have that
precision?
That precision and safety mechanism. Something to fall back on. That next level of ensuring that you are away from the critical structures that you don't want to injure.
That is remarkable.
So it's remarkable. And they have the same thing in large intestine, like colon surgery, or even small intestine, when we have to cut a bad piece out and staple the two ends together. Well, you want to make sure that staple line is getting good blood perfusion. So you click on this thing and it tells you how much is going right there. Is it enough? Is it not? Because if it's not enough, that's going to break down and you're going to get a leak. So imagine what it's saving in complications, patient suffering, and things like that after the fact. All those things that the robot has elevates it above anything that we have, and definitely traditional laparoscopy.
Yeah.
Less post-op pain, quicker post-op recovery, ability to do more difficult procedures safely.
So a patient comes into you and they're hesitant about it.
Sure.
Because maybe they're an older patient, and this isn't the traditional way. It may not have been the way their parents have been operated on, or their partners, or whatever.
Yeah.
How do you win them over?
Yeah.
And do you show them videos?
I just put a nice smile on my face. No, of course. So the important thing with any patient is that, these patients are coming into your hospital. Any patient. They're coming, they don't know you.
No.
You're just another servant. Most of them don't know you.
Yeah.
You're coming in, and no one wants to come to a hospital, let alone to a surgeon's office.
Right.
Knowing that surgeon, you're coming to evaluate something that possibly needs, So gaining the trust and putting that patient at ease is like 50% of forget the actual surgery and doing the operation and having that be successful. Just gaining their trust is like 50% of Not battle, but like the goal.
The goal, yeah.
The goal is to gain their trust, because you're gonna cut them. They have to. So basically, what I do when I see them is I'm as transparent as possible. I don't beat around the bush. I'm very nice and gentle, but I don't beat around the bush. I don't fluff things up. Tell them how it's gonna be, the way it is. And I'm very clear and concise and thorough in providing all the details to them. And then I answer all their questions, but specifically to get them, for the robot, I just go over all those things. Like if I see that they're hesitant, I'll outline clearly, like I just did to you, what the advantages are of doing it open, traditional laparoscopic, and robot.
And how do they usually respond?
They love it.
Yeah.
Once I lay everything out.
Once you say less trauma,
when I say
less recovery.
Pain, when I say less pain, they say sign me up. But most of them, to be honest with you, I've never really had somebody like, no, I don't want it robotically. But most of them, once I kind of give them everything, the overview of everything and the advantages and things like that over other modalities, most of them are like, oh, that's cool. I didn't know that existed. Right. Or we've heard about this, but we didn't know what the details were. And so, it's just, like I said, being clear, concise, and thorough with them, answering all their questions, not rushing them. That tends to go a long way with patients. In anything, but robots.
So generally speaking, I know each patient is an individual case, but generally speaking, on average, how does the recovery time after robotic surgery pan out versus traditional surgery?
Depends on the patient, depends on what surgery.
Sure, there are a lot of factors.
A lot of factors. But if we want to just take one example, so inguinal hernias.
Yes. Okay. Painful as all get out.
Right, So inguinal hernias, again, before even laparoscopy, 6-inch, 7-inch cut in your groin, okay? Open dissection down through multiple layers, identifying that, and then, again, the way I used to do it when I did them open, I put a mesh plug and then a mesh patch and then close that up. It was okay, but, there's still a good amount of recurrence rates with those. Over the years, there's still a good amount of recurrence. Plus, pain. It's pretty painful. There's nerves that are in there.
Sensitive area of the body.
Very sensitive area. There's nerves in there. It's a relatively big incision. You get a lot of swelling in there and things like that. So the post-op pain is pretty moderate to significant for the first 2 days. Traditional so that was open. Doing traditional laparoscopically, the traditional way, very difficult for all the reasons that we talked about earlier. You have stiff instrument tips. And you have to do it you do the case obviously from the inside because it's laparoscopic, right? And so you have to basically create a pocket from the back layer of the abdominal wall down in the groin, open it up, make a pocket working towards the hole. You have to identify the hole, get a piece of mesh in there, and then be able to sew that layer back closed and get the mesh in between. To do that laparoscopically is not an easy task.
No.
It's very difficult to do it traditional laparoscopy. Because of the stiff instruments, it's hard to manipulate, it's hard to sew. With the robot, it's a breeze. I mean, you get in there and with the articulating instrument tips, just the smoothness of the procedure and the integrity of the procedure is much, much, much more improved. And say that this is the hole, open, you're fixing the hole and you're putting a patch in like this. With the robotic, you're doing it like you're putting the mesh on the back side of that.
Oh wow!
So if in theory, if enough pressure is applied to something here from the inside, you can bow that mesh up. Right. If enough pressure is applied.
No way. Yeah.
You'd have to buckle the whole mesh into the hole, which is not going to happen if we do our job right. We have to get overlap. All the way around the same, like a good enough overlap of the hole, right? It's like patching a drywall.
Yeah.
That's exactly what it is. And so I've seen, again, I've done them all three ways. Post-operative pain it's not as significant and it doesn't last as many days. Their return to work is much reduced,
Mm-hmm.
you know, from 2 weeks to less than a week if they want.
Right.
They take more time if they need to,
Right.
but for the most part.
Yeah.
You know, some patients like to complain more than others. For some patients, 10 out of 10 is like a 1 out of 10. Like they're the high tolerance.
Right.
But yeah, so return to normal activities is quicker, post-operative pain is less, return to work is less, return to overall, full recovery is all, it's all short.
Now the other
It's
thing
incredible.
I've heard about, go ahead.
One more thing I wanted to add is that
that's fine.
we see that in the super morbidly obese patients, I'm talking like patients that 350, 400, 500 pounds.
Mm-hmm.
It's incredible what the robot can do, because to do that patient, traditional laparoscopic, you can't get enough torque
Right.
to get that instrument to go where you want. It's just too much fat. There's too much, just too much.
Yeah.
The robot takes all of that away. It takes all, you don't have to provide the robots do the torque, like they're doing the movements, right? You're controlling it, but you don't have to do it. So it's just your ability, like a patient that comes in with a hernia, let's just say an incarcerated hernia, which is a hernia that you have, whether abdominal wall or in the groin, that a loop of intestine has gone through and gotten trapped in there.
Mm.
And that's an emergency, right?
Mm-hmm.
If you can't get it, pop it back in, you got to take that patient to the OR because the clock's ticking, the blood supply is starting to get compromised, right, from squeezing on it. I've done, to do that patient, open, 600-pound, 500-pound patient,
Sure.
open. First of all, I need to rally all the medical students in the hospital to come help me, because to just retract the abdominal wall open to get down through this much tissue to fix the hernia at the bottom of the abdominal wall, it's nearly impossible. And if you do it that way, they're in the hospital for.
And the other thing is, when you have, there's all sorts of reasons why people are morbidly obese, from genetics to addictions to whatever.
Sure, exactly.
And they're as self-conscious as anyone about it. And some of them, what I've heard is some of the most embarrassing things is when they go to the doctor and suddenly they have to account for all of that. And I would assume that lessens some of the.
100%.
Yeah.
It definitely does. Like I said, for example, I did a surgery on a 500 and trapped hernia, incarcerated hernia on a 550-pound woman.
Mm-hmm.
She was in the 23-hour observation. This is a patient that 20 years ago would be in a hospital for a week at least, 10 days. Now she's out of the house the next, like I did her at 5 p.m., she left in the morning.
Wow.
That alone is just incredible to me, the advantages and the positives of that.
And it's less financial stress.
That's another thing. We're not even looking at that yet.
Yeah.
Most hospitals nowadays, often, they look at that. They look in a lot because they need to stay afloat too. They need to take care of patients.
There's a business aspect.
There is, and sometimes those clash. But my point is that of course that's also a variable that you have to look at.
Yeah.
And I've done with Intuitive. They have great data collection.
Yeah.
We've taken my personal experience in cases and then extrapolated those and compared them to national averages. And in Pittsburgh, where I worked before, just the cases that I've done, the potential savings for the hospital was like $1 million. Wow. Think about that. That's just one surgeon.
Yeah.
Right.
And that makes the insurance companies happy.
Of course it does. Yeah. So it makes everybody happy.
Yeah.
And most importantly, the patient.
Yes.
So somebody that's in the hospital for a week, they can catch other infections, they can get pneumonias, because there's where sick people are. So to get them, the quicker you can get them out of the hospital, it's better for the patient, it's better for the hospital, it's better for everybody. So that's what the robot, it shortens. Surgeries that you would keep a person in the hospital for a couple days, now they're out, they're same day. It's the same day.
That's incredible. That's what I've heard about. It's like, it's surgeries that, as you were saying, where you'd be in the hospital for weeks in some cases, in recovery after the surgery. Now you're out in a day or two.
Exactly.
That's incredible.
Exactly.
So it's already incredible.
Yeah.
Where are we headed with it? Yeah, that's the typical human question.
Exactly.
What's next?
I don't know. I'm not sure how much they could do more. But a couple things that's already being rolled out. Obviously, it's upgraded versions of the robot. here in, I guess, remote places, they still have the original. There's like, it started off SI, and it's like the versions SI, X, XI. And so
just like the Super Bowl.
That's right. Most hospitals have XI, which is very new, but there's now, it's called a DV5. It's the brand new one. It's been rolled out. Hospitals have it. Trying to get one here, but I just started, so
we'll get there.
I got to get busier. Yeah, and so, just little tweaks of an already awesome, great system, efficient system. Things like, feedback.
Yeah.
Tissue feedback. Well, think about it. Like when we're operating with our hands, we have sensors. We can feel how much tension we're pulling on something. Well, when you're with the robot, right, you can't feel the tension because you can't feel how much tension you're pulling. It's almost like it has to be a visual cue that you're looking at. Well, now they've developed an ability to measure feedback on how much tension you're applying to tissue.
So now you can
actually.
Now you have that. Now you kind of lost a little bit. Yeah. Wow.
That you lost from that. They've now developed a way.
And it's now quantifiable.
That's a thing you can compare. You can say, okay, you're holding a tissue and something tears, or you're holding something. It doesn't have to be like a really bad complication. I'm just saying, you see that, oh, it tears a little bit. You can see, okay, well, I pulled it three levels. I need to. And it's live, right? So it's like one of those meters, like the audio meter when you're screaming and it goes up. Yeah. It's kind of the same thing, but it's tension. It kind of goes up the bars of the light.
That's remarkable, yeah.
And so now you can see if it's starting to rise, you can back off at least some of that tension.
So you're regaining some.
Yeah, you're regaining some of that tactile sensation, which you lost. Which you were able to do surgery fine without it because we adapt.
Sure.
But again, just like the ICG where it lights it up and gives you. Why not have another extra level of information for you? We talked about AI.
Yes.
They're starting to incorporate AI in this thing. Intuitive, with the company that makes the Da Vinci robot, it's called the Intuitive Hub. And that's most of where the AI is going to be dumped into.
Yeah.
As far as, and it's so advanced, it's hard to explain. It's basically a network of a system that they have that links to the robot console, and it allows anything that is being done is recorded. Like it's right now, if I want to record my surgery so that I can review it, and I have to bring in one of those thumb drives, right? Special thumb drive, and plug it into the tower and have it saved onto that. But with the hub, it's something that they developed, it's already incorporated into the whole system. So it's automatically recorded with no patient identifiers. They've also went through that whole legal. And again, that allows, we don't have that here. We do have, we have a residency, internal medicine residency and emergency medicine. We don't have a surgical residency, but for the teaching hospitals that have surgical residencies, that allows them, their attendings to, review in real time, or say that you have a partner who you're in the surgery and you get in a difficult spot and your partner's not in the hospital physically coming to the OR, he can pull up his laptop and pull up the surgery that you're doing.
Wow. That's what I was thinking.
A live stream of it, basically.
When you said hub, I thought, so it's centralizing all of this data, and now you can have help. You can have
help. You can have communication. You can have review session.
You can sharpen your skills.
What else?
Whereas before, when things would go wrong, it was like, we think this is what happened.
It's exactly now. It's documented.
That's
and they say, well.
And that data and documentation,
transparency, and then all that, and then another thing. It's obtaining data from all the surgeons in the United States that are using that.
Wow.
So imagine
I was about to ask you about that,
of research that they can do.
So what it's going to
Imagine
do
that.
is it's giving not just data for you, for your partners, for the entire,
whole medical,
which is going to just
world.
amplify progress.
It's just going to amplify progress.
Wow.
That's the big thing, and that's already available. Again, I'm sure with time, AI as they incorporate, that's going to get tweaked to a very precise level and efficiency level. But that's already out there. And so these things like this are the future of robotic surgery. It'll never get to the point. You always need a surgeon.
Yes.
Okay, they're not going to just because never going to get to the point. You need somebody to be able to adapt on the fly.
Right.
You know, and I'm not sure with all the AI in the world, I'm not sure it's going to be able to do that.
Right.
And so, but to continually improve product,
Yes.
robot, to allow, to make it, I wouldn't say easier for the surgeon, but to put in his arsenal of tools,
I would say more precise.
More precise, right?
Yeah, more informed.
More informed, more precise, more technical.
Mm-hmm.
All those things translate to less trauma, to more efficient surgeries,
Yeah.
because one thing you have to think about, the patient risks mostly aren't from the surgeon, it's actually from the anesthesia that they're getting.
Right. Yes.
And the longer they're under that anesthesia, the more potential for complication.
Yeah.
The higher the risk for a complication.
Yes.
So
Anesthesia
I'm not
can mess
promoting
patients up for
absolutely,
days, if not weeks.
exactly. And so the longer the surgery is, the more anesthesia they're getting. And so I'm not promoting trying to be a very quick surgeon. But
Right.
if it's something that's very hard, you take your time and you do it correctly.
Yeah.
Speed is not. But inherently,
Yeah.
when you add all the advantages that the robot can provide to the surgeon,
Yeah.
it's going to speed up the surgery. No doubt about it. It's just going to speed up the surgery.
The other thing I was thinking, and I may be a field in how,
Yeah.
you mentioned that with these live streams, there's no patient identifier.
Yeah.
So, and if you're collecting data from other surgeons and their surgeries, I guess it would be possible then you have the stats on the patient you're about to operate on, and maybe it's something that you really haven't had a type of patient you haven't had a lot of experience
Exactly.
with. So you can just dial up.
I can dial up. I could type in whatever that problem is or whatever that situation I haven't seen. And if anybody has dealt with it operatively, any surgeon in the country, boom, that video is right in my face.
Wow. And
I
you
can review it.
Oh,
I
wow.
can review it, stop, start. It's like being at film on
Yes.
Monday morning
Yes.
after football.
Yeah, that's remarkable.
It's incredible, the teaching level of, not only for the surgeon,
Yes.
but imagine like the surgeons in training coming up, right? The medical students or the residents that are in it now.
You have
The advantage that they have with that is incredible.
You have to be so excited in the field you're in. It's got to get you out of bed in the morning.
I do. When I'm in the operating room, I'm not going to lie. I can't say that it's not stressful. It is. You have patients' lives in your hand, but it's the happiest place.
Yeah.
When I'm in there, we don't want to be anywhere else.
Yeah. Right.
We have to see patients in the office. We have to see them and follow up. It's part of the job. The most exciting part is being in the operating room. So, yeah, I'm super excited. Again, when I keep seeing the advances that they're making, I feel like it's hard not to feel like, yeah, hey, they did that for me.
Yeah.
Even though they're, but
and the causalities from a surgery, especially an intricate, intense surgery. I would imagine it also. You were talking about the trauma on the body, but we don't often talk about the mental health trauma that comes from surgery.
Absolutely.
Yeah.
Great point. Somebody that comes in for an elective surgery and has elective hernia repair, has a complication, ends up something that they should be recovered and back to normal in 2 weeks, takes them months and months, something, wound complication. That's undoubtedly going to cause some mental trauma.
Oh yeah,
for sure. And then in general, or if some patients come in and they present with a very advanced problem and they have to have emergency surgery and do all that. Yeah, I mean that will definitely alter somebody mentally.
Yeah.
But if you could get them out of that situation to the best of your ability and to get them as good as they can be and optimize that recovery, you know, I think you take a situation where mentally they may go the opposite way because they come in down, depressed, in an emergency state, and you save their life or you drastically improve their life, and they go back and now they're doing things that they haven't been able to do in years. I have that side too. I mean, I can't tell you how many patients have come to my office who have cried and they just said, "Doc, you completely changed my life. 3 weeks ago, I couldn't even go to Target and walk around." She goes, "I've been there for 3 days straight because all I want to do is walk around Target because I'm able to do it now." And so, like, you know, you would think that's life.
It's life-giving. Yes.
It's life-giving. It's transforming for those patients. Because when you're going through your daily life, the mundane things, it's like second nature to you. Like going to get groceries seems like second nature. It's, you know, you don't think about it.
But when you have chronic pain.
When you have chronic pain, you can't literally walk to be able to go get the groceries. And now you can.
Yeah.
It's hard to, I can't describe that feeling, but I've seen the reaction and I've seen how my patients feel after doing it. And so that's why you do it. This is what makes you get up in the morning and things like that. Yeah, it's a stressful life. You get to see less of your wife and kids and things like that.
Right.
But in the end, moments like that, when you change somebody's life, you're like, you get this like feeling that goes over you, and you're like, that's why I went into it. This is why.
Why you went to 14 years of school and
tortured myself.
Yes.
Still tortured myself, but that's okay.
Well, it's an honor to have someone with your breadth of knowledge and experience here and working for our community. We have a lot of, as you've probably discovered and learned, we have a lot of comorbidities in this area.
Yeah.
A lot of elderly folks who need your help and need your assistance. So we're so grateful to have you. Any final thoughts before we wrap this up?
Well, I just want to say, so far it's been a month here at Trinity, and everything has been wonderful so far. Everybody's very outgoing, positive.
Yeah.
Nowhere is perfect, okay? But after being here for a month, I'm surrounded by people that I can see just want to help the community and make the community healthier. And if I can add to that while I'm here, I'll be a happy guy, and I'm looking forward to it.
Well, I hope you'll come back on as we get more improvements and as we get some of the technology we're talking about.
Sure, we'll give you updates, absolutely.
I'd love to have you back on.
Perfect.
Well, thank you so much for being here. I appreciate it.
Thank you.
And thank you folks for tuning in, listening, watching, however you took in this podcast. I hope you check out our YouTube channel, Trinity Health System. You can find the Trinity Talk playlist there. And we will see you next time. Thank you so much for tuning in. Thank you.